I'm presenting on the topic of human herpes 8 positive multicentric Castleman'S disease. It's a case series. I'm Dr. Frank Mukonde from the Kitwe Teaching Hospital and Department of Internal Medicine. This study was prepared with Dr. Francis Msonda, who's the consultant pathologist, and Dr. Luishana Makando, who's the consultant physician as well as the head of clinical care. So, what is Castleman'S disease? This is a disease that was described in 1956 by Mr. Castleman and others. They described it in a group of patients in whom they had noted that they had hyperplastic lymph nodes, and that's a common presentation, is generalized lymphadenopathy. It has 3 subtypes. One is unicentric Castleman'S disease, which affects one area lymph nodes. It could be in the abdomen or it could be in the chest. Then the second one is human herpes virus 8 associated multicentric disease, which also will present with lymphadenopathy, flu-like symptoms, as well as abnormal blood counts and dysfunction of the vital organs. We also have the human herpes virus 8 negative, or the idiopathic Castleman disease, which will present with symptoms like the HHV8 associated Castleman disease, also of flu-like symptoms, abnormal blood counts, and dysfunction of the vital organs. There is limited data on the prevalence of disease in Zambia, so that's why we decided to bring this to the presentation. The data looked at for the United States, they mentioned that they see about 77,000 cases of Castleman'S disease per annum. So this is a case series, as I mentioned. So I'll present 3 cases. 2 HHV8 positive, and 1 is actually HHV8 negative and also HIV non-reactive. So the first one was male, 42 years, who had a long-standing history of intermittent fever and chills, but at the time of presentation, he said that he just had these symptoms for a week. He's been on ARVs for 3 years and is said to be compliant, and he was treated for presumptive tuberculosis in 2015 based on the lymph nodes he had. These did not disappear, so in 2018, biopsy was done, which was suggestive of Kaposi's sarcoma because of the spindle shaped cells which were seen there. And it was advised to do an HHV8 test, which he didn't do. So at the time of presentation, he still had generalized lymphadenopathy and he had splenomegaly. So a repeat biopsy was done, and that showed that he had what will show this later, this onion skin architecture, which are inconsistent with the Castleman'S disease. So immunohistochemical staining was done, and it confirmed that it was HHV8 positive Castleman'S disease. So he was referred to the hematologist. He was put on chemotherapy. This has induced disease remission and symptomatic relief, and he hasn't had any recurrence up to now. The second case is that of a female, 28 years old, also presented with recurrent fever, weight loss, and anemia. For this, she had received multiple blood transfusions, and also she had been on ARVs for 2 years and noted that she was also compliant. She was also treated presumptively for TB, tuberculosis, in 2018. So this year we decided to do lymph node biopsy because she has generalized lymphadenopathy together with this immunohistochemical staining for HHV8. So the lymph node biopsy also showed a onion skin ring architecture, and also he had lollipop lesions, which will show when we get down to the slides. The third case is of a young man aged 20 years. This one is not is HIV negative and was HHV8 negative. So this is a case of idiopathic multicentric Castleman's disease. He was diagnosed as having sickle cell disease at the age of 16, that is 4 years ago, using a sickling test, and this was not followed up with HB electrophoresis. So the basis for suspecting sickle cell disease was that the patient started presenting with recurrent anemias and a big spleen. So he was being managed as such until this year when he started having recurrent admissions in hospital for enlarged spleen and also recurrent anemias. Whilst on the ward, he has developed this syndrome called Tafro. So the T is forced from the cytopenia. This was evidence from the full blood count, and he had generalized anasaka, and also his bone marrow had showed some enlarged cells, and which looked like macrocytes. And also he had organomegaly, as mentioned, that he had a spleen. So even him, we did a lymph node biopsy, keeping in mind that the patient who has a lymphoma or any malignancy, their sickling test could actually come out positive. Bone marrow aspirate was done, and HB electrophoresis was done to confirm the sickle cell disease. So the sickle cell disease was actually disproved by the HB electrophoresis. And then the lymph node biopsy as well showed that he had the onion skin ring architecture with the lollipop lesions. So when it showed the images for one, because they were looking the same, they had almost a similar appearance for the test done. So here in the lungs, you see that there's some nodular lesions, but you can see that it's an air filled sac in the lung. And then in the abdomen, we see a number of lymph nodes there. So they had generalized lymphadenopathy, and this also extended to the internal organs. So this is the onion skin architecture, which is consistent with the Castleman's disease. And it was present in all the 3 cases that have been presented. And here we are seeing a lollipop lesion. So what you see is that this onion skin architecture, which you see here being distorted, it's also being distorted here. So it's invaded by the blood vessels, the arteries. So it loses its architecture because of that invasion. But this is a lollipop lesion that is also consistent with the multicentric Castleman's disease. And generally, we can see hyperplastic follicular hyperplasia generally in the cells. So in conclusion, this case series report shows the importance of obtaining a definitive histological diagnosis and immunohistochemical staining in HIV patients presenting with generalized lymphadenopathy and systemic symptoms. This is so because we've seen that it can mimic any disease, and that it's important that a definitive histological and immunohistochemical diagnosis is obtained. So from this, the recommendation is that there's need for clinicians to have a high index of suspecting Castleman's disease, as it mimics other diseases that present with systemic symptoms, as we saw fever, chills, and weight loss and generalized lymphadenopathy. There is also a need for setting up cheap manual histochemical chemistry services by the laboratory units so as to reduce in the delay in the getting of results. So we needed to rely on the private labs to help us with the immunohistochemical staining. And also there is need for immunohistopathological staining in those presenting with generalized lymphadenopathy, especially if they are living with HIV/AIDS disease. Thank you very much for listening.